Good morning, everyone. As we are at the top of the hour here, I'm gonna give it a couple minutes, let people filter in, and we'll get started here shortly.
Hello.
Hi, James. We're just getting ready to start.
No worries. I'm ready.
Okay, it looks to me like the number of folks jumping on is kind of slowed down and everything. So just to respect everybody's time, we'll go ahead and get started here. Let me share my screen super quick here. I'd like to welcome everybody today to this H5N1 avian influenza situation report update. Just real quick here, a couple of the topics that we're going to be discussing today, talking about our current risk status, some of the growing concern from experts around the current H5N1 outbreak, and how some of the other nations around the world have raised this pandemic alert levels, and what we can be doing here in the US to respond to that. Just as a reminder to folks, we'll be utilizing the Q&A in your chat box or in your Zoom right down there at the bottom. We have also enabled it so that you can actually upvote your Q&A. So if there's a topic that you see that you want to particularly answer, let us know and we'll make sure that we prioritize that one. Then as far as our speakers today, today we have Dr. James Lawler. Dr. Lawler is the Director of International Programs and Innovation at the Global Center for Health Security. In 2018, he came to UNMC following a military career in which he served as a Navy commander and was Chief of Clinical Biodefense Research at the Naval Medical Research Center, Fort Detrick, Maryland. He was an attending physician at Walter Reed National Military Medical Center and served White House assignments as Homeland Security Counsel and National Security Council staff, where he worked on biodefense, pandemic response, and health preparedness. Dr. Lawler has field experience treating Ebola patients in sub-Saharan Africa, and he has served as a subject matter expert in the training of Department of Defense medical personnel working with infectious disease patients. He is board certified in infectious diseases. We also helping us out today, Shelley Schwedel. Shelley serves as the as the Executive Director of Emergency Management and Biopreparedness at Nebraska Medicine. In addition, she serves as the Associate Director for Clinical Operations and Emergency Management at the University of Nebraska Medical Center, Global Center for Health Security. Shelley has 40 years of healthcare leadership experience to include emergency, trauma, preparedness, and accountability for biocontainment unit operations and logistics during the care of repatriated Americans with Ebola virus back in 2014-15. And leadership in collaboration with local, state, and federal partners to support quarantine missions for repatriated Americans from Wuhan, China, and others returning from the Diamond Princess cruise ship from Japan who required care for COVID-19. And with that, I will actually turn it over to Dr. Lawler to get us going.
Thank you, Thomas. Let me turn on. It's not letting me start my video, but I can share. So I guess that's really the important thing. All right. Hopefully, folks can see my screen.
You should be able to turn your video on now.
Oh, all right. Well, too late. So we'll go ahead and get started. A lot of things to cover here, and want to get some time for questions as well. As Thomas mentioned, and maybe some of you have been seeing in the news, there's been a little bit of coverage in the media about increasing concern for H5N1, this current outbreak that we're seeing of what is the clade 2344B virus. And I think it's helpful to put that in context of how we've envisioned pandemics unfolding, at least in our planning scenarios and based on experience over the last several decades. And so this little stepwise diagram shows what those different stages are in kind of a canonical recounting of the emergence of a new influenza pandemic. It starts with a new virus, and in general, those viruses emerge in animals, since flu is really mostly a disease in birds, in wild birds, and that's where most of our new flu viruses actually have their genesis. And then this new virus that appears in birds sporadically jumps into humans and other mammals. Typically, pigs are seen as the most significant mixing vessel for these viruses, and that's that combination of birds and pigs that often produces a virus that's then able to jump into humans. But nevertheless, we kind of expect to see these sporadic jumps of a new virus into humans as it's starting to adapt and get to know us and develop the capability to spread more effectively from person to person. And when that happens, we expect to see a growing number of human infections, and then eventually sporadic human to human transmissions. And now it's not just jumping from the animal population into people based on animal exposure. There's now periodic transmission of person to person, and then eventually we get sustained human to human transmission, and that's what leads us to a pandemic. So if you think about where we are now with the current H5 clade 2344B virus, which is the one that's causing all of the kerfuffle here in the US and has really been the virus that's dominated globally over the last couple of years, I think it's safe to say that we're somewhere in this neighborhood here, where we've seen sporadic jumps into humans, but now we're starting to see evidence of a growing number of human infections. We don't have evidence currently that there is sporadic human-to-human transmission, but that's not out of the realm of possibility. So honestly, I first made this slide up a couple of weeks ago, and I would probably start to slide that arrow up and to the right, that red arrow showing where we are now, because I think we're probably getting into the growing number of human infections neighborhood. And if you think back, this has again been the envisioned progression of events for decades. And this document here from 2006 was our national strategy for pandemic influenza and the implementation plan. And you can see those phases of pandemic emergence and where we are given the WHO and at the time US government assessment, and certainly by the WHO standard, we'd be somewhere around pandemic phase 3 or the pandemic alert period. Interestingly, or sadly perhaps, on the right, you can see that all of our federal government preparations were really based on the assumption that a novel emerging virus would start overseas. And that was a reflection, I think, of what was happening at the time with H5, which was predominantly seen in Asia and had originated in East Asia. But obviously, with the experience of the 2009 H1N1 pandemic, which emerged in North America, and then obviously this current potential pandemic virus, which, although it may not have emerged in North America, this current clade has been misbehaving most prominently in North America. Maybe we should rethink how we plan for that. And just a little bit of background on flu virology, on why an emerging H5 virus is so important. Remember, the structure of influenza virus, it has these two major proteins that are displayed on the surface. The hemagglutinin, which is the dominant antigen, that is the protein that's responsible for attachment to cells, and then the neuraminidase, which is the other major protein, which is responsible for cleavage from the cell and proliferation of the virus to infect more cells. But these are the two surface proteins that your immune system recognizes. And so the major immune response against the virus depends on the identity of those two proteins. And obviously, proteins that we've seen before, or at least close relatives, we have some immunity against. You can see that there are 16 total hemagglutinin and influenza A viruses that humans have only seen a small subset of, and there's 9 neuraminidase options. Remember, the circulating seasonal influenza viruses now are all H1N1 or H3N2. And so this new H5N1 virus, certainly the hemagglutinin H5, is something that most humans have never seen before. And so that gives us concern. If we had a virus that was able to spread widely from person to person, we'd have essentially very little immunity in the population. So major pandemics for influenza that have occurred since the beginning of the 20th century, when we've been able to track influenza pandemics, show us that when you have this major antigenic shift of moving from one hemagglutinin and neuraminidase combination to a new combination, that's when you get pandemics. So in 1918, previously, we don't know exactly what virus was circulating, but in 1918, H1N1 emerged and was the dominant virus on the scene for the next 40 years. It was replaced very quickly by H2N2 during the 1957 pandemic. So again, everybody in 1956 had seen lots of H1N1 viruses, but nobody, certainly nobody under the age of 40 had ever seen an H2N2 virus. And so the emergence of that virus caused a major pandemic in 1957, not as severe, obviously, as 1918, but still a pretty major episode of pandemic influenza. The next pandemic occurred only 11 years later in 1968 with the emergence of H3N2. Again, a totally new hemagglutinin that people had not seen before. And so that was responsible for obviously a global pandemic that replaced the H2N2 virus. Interestingly, in 1977, H1N1 reappeared. It did not cause a severe pandemic, and partly because obviously everybody who was older than 20 years old had been seeing H1N1 viruses previously. Lots of good history to read about the H1N1 emergence in 1977 because it probably came out of a lab in the Soviet Union. So if you're into history and bio mysteries, that's a good one to read about. And then obviously the new H1N1 virus that is currently circulating along with H3N2 emerged in 2009. So again, whenever you have this antigenic shift, right, a new hemagglutinin, generally a hemagglutinin, but also the neuraminidase along with it, when you have new ones that appear, it tends to cause a pandemic. Why hasn't H5 caused a pandemic until now? Well, one of the theories is at least that H5 viruses so far have been relatively selective for binding in the entrails of birds. So in birds, influenza is generally a GI illness, right? It's an enteric disease. And birds, both in their respiratory tract and in their enteric tract, have high concentration of a certain configuration of the sialic acid receptor that is responsible for binding for the virus. And so birds that have this strong predilection for this alpha-2,3 configuration of sialic acid on galactose have a predilection to bind the current H5 viruses. Now, humans have a predilection of alpha-2/6 configuration in the upper airways, and so seasonal influenzas viruses bind that upper airway alpha-2/6 configuration. However, in the lower respiratory tract in the lungs, humans actually have a predominance of alpha-2/3. And so while it's difficult for most current H5 viruses to bind the upper airways, which means it doesn't transmit very effectively from person to person, when somebody does get infected, it has a tendency to bind in the lower respiratory tract and cause pneumonia. Now, pigs have both of these configurations, 2/3 and 2/6. One of the reasons why they're considered to be a bit of a mixing vessel. But now we're also seeing that the udders of cows, the mammary tissue of cows, which is something that we had not thought about or considered for influenza viruses before, appear to have potentially both alpha-2/3 and alpha-2/6 configurations. And so this means you're essentially giving the virus a large volume of tissue in which to replicate that has both receptors, and potentially training the virus to be able to bind effectively to both, which would, in all estimation, be then a very dangerous virus for people, able to transmit person to person, and also potentially able to cause severe disease. Now, even though H5 viruses have not shown a tremendous affinity to infect humans so far, they certainly can infect humans, and there's been now, roughly 900 cases of human infection with H5 since 2003, and you can see from this WHO chart of the documented infections we have from H5N1 in humans, the case fatality ratio is actually quite high, greater than 52%. Now, we're certainly not catching all of the true infections that are out there, so this CFR is probably quite a bit lower. But even if it's 10 times lower and the case fatality ratio is only 5%, that's over twice the CFR of the 1918 virus. And so this has shown itself to be a very dangerous virus when it does infect humans. And again, the concern would be if it is able to mutate to a form where it can transmit more effectively from human to human, even if it loses some of its virulence there, that's still an incredibly dangerous virus. The other thing that's concerning to me is if you look at the case reports of H5N1, again, since the early 2000s, there's a strong tendency of this virus to at least manifest in younger patients. So you can see here the vast majority of patients who've been documented with H5 infection across the world are under the age of 30, and indeed the majority are under the age of 15. So this is obviously a profound difference from what we've seen with the current COVID pandemic, where it is the elderly who are most significantly affected, even though the young are probably infected more frequently. But this also corresponds with severe disease that are seen in these populations, and a little bit more reflective of the 1918 virus, which was able to cause very severe disease in young populations, unlike what we see in seasonal influenza. And so that was one of the reasons why the 1918 pandemic was so devastating. So this has all led a number of experts across the globe to really start expressing concern about this virus. And it was only recently, in the last couple of weeks, that the UK Health Security Agency actually upped its pandemic risk assessment to the highest level it has been. And the Health Security Agency is a new agency that was started in response to COVID in the UK, but the UK has been doing pandemic risk assessment for a while. And so this UK risk assessment of 4 is again, obviously the highest it's been, and it talks about here, as you can see, we're seeing sustained and multi-species mammalian outbreaks, increasing human zoonotic cases, or limited person-to-person spread. And so we are only a couple of steps away from that sustained human-to-human transmission, which essentially means that we are in a pandemic. So increasing concern, I think, across many experts about where we are with this current virus. In that press release that came out with the Health Security Agency warning, you can see the director of HSA talked about the fact that this virus continues to infect new mammals and spread between them, in addition to the increasing number of human cases we've seen. And if you look at how the HSA kind of affixes their risk assessment, this level of risk for this virus seems to indicate that they think there's somewhere between a 1 in 10 and 1 in 3 chance that this will become a pandemic virus. I think that's honestly a bit aggressive and probably higher than the odds that I would give it. But nevertheless, the bottom line is whatever the risk or threat that this becomes a human-to-human transmissible virus, the impact of that and our vulnerability to that is quite high. And so that would be, I think, by reasonable estimation, a pandemic that would match the severity of 1918, potentially exceed what we've just experienced with COVID, and would be certainly something that had a dramatic impact globally. So I think it's fair to say we should all be concerned. Now, a little more background about this current clade of virus and what we've been seeing with H5 over the last couple of years. As you can see from this map, from the mid-2000s up to 2019, represented in panel A, we've seen a dramatic jump in the global spread of H5 virus infecting birds and mammalian species, which you can see in panel B. And this is all really in the last 2 years due to this clade 2344b that we're seeing now in cattle and wild birds in the US. And this virus has also been responsible for widespread outbreaks in birds and mammals, especially sea mammals in South America, which has had documented high levels of mortality in these sea mammals, such as dolphins, sea lions, seals, and also pretty clear evidence of mammal-to-mammal transmission in these species, which is, again, something that's relatively new and unusual for H5 viruses. We've seen this also in mammal and wild bird populations in the US, and you can see all of the different mammalian species on the right that have had documented H5 infection here in the US in the last few years. And here's where we are in the current situation. So again, it's not just in cows. You can see there we've had 189 dairy herds affected, but we've had 14 human cases now documented in this most recent outbreak. It says since 2022, but really all of this has been since April of this year. We've had 4 human cases associated with exposure to dairy cattle and 10 associated with exposure to poultry. Most of those, 7 of those, at least 7 or 8, came from a recent episode in Colorado where a large poultry culling operation was responsible for a number of human infections. Again, we've had 189 documented dairy herds infected since March. But what's not necessarily as widely reported or understood is we've had over 100 million poultry that have been affected, either died or mostly culled in almost every state in the country. Essentially, I think all the lower 48 states have had cases of avian influenza in birds. And we've had lots of testing going on in people, as you can see there, 39,000 samples plus, which sounds impressive when you think about it. Tests that have been done, essentially over the last year, at least since February. But if you look at it in context, about 100,000 US citizens present to healthcare every day with signs and symptoms of respiratory infection or influenza-like illness. And so, roughly testing 1/3 of, a day's burden on the healthcare system, over the last, 7 months, 6 months, doesn't seem as impressive as you might initially think. Also, we've had, obviously now 14 documented human cases, but we've only tested 230 people. And that's kind of crazy to think about. Since March, we've had this ongoing outbreak with, tens of thousands of workers in the agricultural industry potentially exposed, and we've only tested 230 people. So when you hear reports about we're not, we're only seeing this virus in, a confined number of herds and in a certain number of states, the reality is we're really not testing very much. And here's the current map of where we've seen at least dairy herds that have been affected. And you can see that it's across a large swath of the middle of the country. And, I would argue that most of the states that are not currently colored in, especially in the middle of the country and in the South, where there's large dairy herd populations, probably do have cases ongoing. And this is something that was just discussed on a call I was on this morning, that the fact that, essentially dairy producers are not allowing their veterinarians to test their animals, nor are they allowing USDA or FDA investigators access to their facilities and their farms to test animals or people. And so we are essentially taking the strategy of burying our head in the sand and not looking. There have been a couple of instances now in Colorado and Michigan where those two states have taken a bit more of an aggressive posture in testing, and Colorado has just implemented bulk milk testing, which is great. And that's the other thing I should point out is, over the course of the last few months, there have been several studies that have looked at virus levels in commercial milk. And I think you'll be seeing a news release coming out today about the latest results of tests. So I won't spoil it, but I think it's safe to say that you won't see much change from what's been reported previously, where I think the FDA has detected about 20% of commercial milk products have virus detectable in that milk by RNA testing. Now, there's no live virus that's been isolated from any of these products that have gone through the pasteurization process. So we know that pasteurization should effectively eliminate viable virus from commercial milk. But it's also true that raw milk is consumed by a shockingly large number of Americans. At least 1%, I think, consume raw milk on a regular or a semi-regular basis. And in many of the samples of milk, this milk has been teeming with virus with very high levels. And so that presents potentially a significant risk for ongoing introduction to humans and, again, potential development of a virus that can transmit effectively. Last thing to talk about that is just the more opportunities you give a novel virus like this to infect mammals and potentially people and infect them over and over again, the more you are potentially adapting them to become more transmissible in that species and potentially more virulent. This is a common experiment we do in virology when we're adapting a virus to a new species. And so we're essentially conducting this experiment in nature on a massive scale currently. Some additional data that just came out relatively recently in the last week or so, again, providing a little more evidence that the actual size of the iceberg is much bigger than what we can see. This was a study out of researchers from University of Texas Medical Branch, Galveston, that looked at a couple of dairy farms in Texas that had outbreaks in April. And you can see they tested only a small number of people between two farms, 17, the vast majority of which, were Latino. Most of these are migrant workers. Many of them are undocumented. One of the reasons why we have difficulty accessing workers for testing. And you can see that many of them, in fact, the majority of them in the last year had some respiratory illness. About a third had had a respiratory illness recently. Interestingly, a pretty big discrepancy between these two farms in terms of vaccination status. I think it's safe to say that, more farms are probably aligned with Farm B there, with very low rates of vaccination for influenza and COVID. And a relatively small number, you can see only about a third of the total number tested between the two farms were milkers, who are the ones who have the highest exposure to milk, where most of the virus is and the highest risk. So many of these were low risk people. Nevertheless, you can see that 2 out of the 14 people that were tested and got results actually tested positive for antibodies against H5N1 virus. And so seems to indicate that a relatively decent number of folks, around 15% or so, at least from this small sample of workers who had worked in farms that were infected, appear to have had undocumented previous infection with the H5N1 virus. So if you extend that potentially across the entire population of workers working with these animals in the US, that is potentially a large number of people who've been infected with the virus already. So what does this mean for healthcare systems, and what should coalitions and individual healthcare facilities be doing? First is kind of thinking about and assessing the risk of what happens when somebody shows up at our door with evidence of an H5 infection. And there's, I guess, three scenarios to consider here. One is that this is another sporadic case of animal to human transmission that we've seen in these previous farm workers. And so right now, the virus has not necessarily shown a huge ability or a huge adaptation to spread effectively from person to person. And so you could argue, if we're just seeing another repeat of this, it's probably low risk that this represents a risk for nosocomial infection and spread in the hospital and in the community. And so maybe taking kind of the regular precautions we would take for any influenza virus might be a reasonable approach. Now, the second scenario is that what we're seeing now is perhaps a virus that is starting to develop some mutations that adapt it better for human infection. We've seen some of that in some of the viruses that have been detected in cows and people, particularly the viruses in Texas have had a PB2 mutation, a mutation of one of the genes that seems to render the virus more effective at infecting mammalian cells. And so maybe we're seeing more mutations, and the reason we're seeing a human case now is this virus is a little better at infecting humans. So in that case, it's probably a bit of a higher risk in terms of the possibility for human-to-human transmission and the risk that this person would present for nosocomial infection or spreading more disease. And so maybe some more intense infection prevention control precautions would be in order. And then finally, the scenario would be this is somebody who is maybe a family member of a farm worker, or somebody who randomly acquired the infection from somebody else. And if it's a farm worker, it's hard to tell definitively if they got it from an animal on the farm or another person. And so in this scenario where you have now human-to-human transmission occurring, I think most people would assess this as high risk. Now we have a virus that's shown that it's capable of jumping from human to human, and this is probably a much higher risk to become a pandemic virus, and we really should take very aggressive infection prevention control measures, like putting somebody in a biocontainment unit and using our national tiered system for high consequence infection management. And the problem that I would present to you is that when somebody presents at your doorway, and even a couple of days into their clinical course of illness, you're not going to know the answer to this question. And so, we've had this discussion among the regional emerging special pathogen treatment centers, and I think it's safe to say that there's a divergence of opinion across those folks. I think most are probably aligned with what our institution is planning to do, which is to admit these people to our biocontainment unit and to take the highest precautions until we know more. Because again, I think until you know which of these scenarios you're in, it's impossible to make an accurate, informed decision. So overall, what should healthcare be doing in response to this current outbreak? I think the first thing is that we really need to ramp up our surveillance, detection, and diagnostics capability. We need to be aware of what's happening out there. Our clinicians, especially on the front line, need to be aware, and they need to be on the lookout for clinical syndromes and epidemiological risk, which would make somebody, potentially have a higher clinical suspicion level for H5. In addition, we really need to be testing folks that come in with symptoms consistent with respiratory infection, influenza, and conjunctivitis as well, right? Because we've seen conjunctivitis in a number of these cases. We need to be testing those people for influenza, and we need to be testing if we have the ability in a way that subtypes this virus. So not only giving us an answer of influenza A, but allowing us to identify whether it's H3, H1, or neither, in which case that's concerning. We need to be able to identify these persons of interest or persons under investigation and provide an appropriate response. At a minimum, we should be isolating these folks in respiratory isolation. The types of additional precautions and where you do that, I think, is an institutional decision for now. But as I said, our team is erring on the side of caution. But these patients need to be identified quickly. They need to be isolated quickly, and then public health needs to be informed so that additional testing can be done if warranted. We obviously are doing this to prevent ongoing transmission, and so therefore the respiratory isolation piece is really important. And then finally, when these folks are identified, they really should be treated with neuraminidase inhibitors. That's Tamiflu, right, is kind of the most common one we use in addition to supportive care. But the early administration of neuraminidase inhibitors across influenza in general is shown to be effective at reducing time to resolution of symptoms across all age groups. It's also shown to reduce mortality. And there's been a strong association with lower mortality in H5 infections with patients who've been treated early with neuraminidase inhibitors. And that's the thing about all antivirals. It's the same thing with Paxlovid and COVID. You have to give the drug early. And giving it early means you have to give it to people who aren't very sick. Because if you wait until they're really sick, it's too late. And so that's kind of a bit of a conundrum that clinicians get into, and patients too, is that they say, well, I've only got a bit of a sore throat and a runny nose and a low fever. I'm not that sick. I don't need antivirals. That's exactly when you need antivirals, because if you wait until you're intubated in the unit, it's too late. The drug isn't going to work. So you have to treat people when it doesn't appear that they need treatment. There's a number of diagnostic tests that can be used to subtype influenza A, but they are not the majority of influenza tests that are out there in your laboratory. So that's something to be aware of. But this is important because it allows you to identify not only whether the virus is influenza A, but again, whether it's H3 or H1. And so if you're able to do this, and you come up with an answer that you have an influenza A virus, but it is not H3 or H1, right? It's neither. That's concerning, right? Because then maybe you have an H5 virus, and those viruses need to be sent immediately to public health for confirmatory sites, testing and sequencing. So we need to be aware of the risk. We need to screen patients who present with influenza-like illness, acute respiratory illness, or conjunctivitis. And you need to ask specific epidemiological questions about their exposure. You need to identify those people who are persons of interest. You need to implement appropriate infection prevention control for those people. And then you need to test those people for influenza. And again, I think we should be testing everybody who presents with those symptoms into our healthcare system for influenza, but particularly folks who have risk factors. And ideally, if you can find subtyping tests in your facility or in your laboratory network, you should do that. Remember that sometimes a single influenza test isn't always enough to rule out infection. That is especially and particularly true if you're using antigen testing, because antigen tests are not very sensitive. So PCR testing should be seen as a gold standard. But even for PCR, just as we see in COVID, sometimes you need to do more than one test to confirm the presence of the virus. So a high index of suspicion should make you test potentially more than once if you get a negative answer. And then again, if you have a flu A positive, but not H3, H1 virus, you need to send that on for further testing and sequencing, and you should be concerned about that result. And then obviously in all cases, we should notify public health early. So that's all I got. Thanks. I'll turn it over to Shelley.
Great. Thank you, Dr. Lawler. Always really good background and detail on these topics. So next, I want to quickly run through some resources that we're going to have available to everybody so that we can start practicing some of what Dr. Lawler just walked through as far as respiratory isolation and how we would navigate some of those resources. So let's go to that, and then we're going to open it up for questions here in just a moment. So this is the resources that the National Emerging Special Pathogen Training and Education Center has available. So we have self-evaluation tools for hospitals if you want to just better understand, how your hospital is doing when it comes to being prepared and ready. We have an EMS self-assessment tool. We've got some respiratory specifics. We've got a nice module on identify, isolate, and inform. So if you're looking for just a quick module for some of your frontline team to do, we have that. And then we also keep regularly updating our blogs as far as the high path avian influenza and other useful resources linked to that. So feel free to go to netech.org and you'll find lots of good stuff out there that's free for you to just download, use, and encourage others to take action on. Next slide. A few other nice resources that we'd like to make available to you is some SIT reports that we've got on the RDHRS website. The Global Center for Health Security, where Dr. Lawler and I work here in Omaha, has what's called the transmission, and it's a newsletter that comes to your inbox every Wednesday, and it's got the latest information. So we have a team that collates all of the various data out there of what's happening on all sorts of different viruses and pathogens. So very significant wealth of information there. ProMed is a great source. Several people access this and it comes to them regularly when something is out there that we need to be paying attention to. We have also some new Joint Commission requirements. So for those of you who live in or work in a healthcare facility where your Joint Commission accredited, some new standards went into place July 1 that really does require you to think about how are you going to quickly look at symptoms and travel history. How are you going to isolate? How are you going to inform public health? So what's the sort of strategy behind identify, isolate, and inform? And then in addition to that, really having a plan for cleaning and disinfection, knowing how to don and doff PPE correctly and having a protocol for that. So lots of good information again on this link, and we'll get these slides out to everybody who attended today. We also want to make available to anybody who's interested in having part of our team from Region 7 reach out and walk through and do some training with your team. We can help with those self-assessments. We can also come and do a site visit. So we've included Jackson Gruber's email there at the bottom, so feel free to reach out to him with any questions, and we'll do what we can to really help anyone who is interested. So next I want to go to the questions. So Dr. Lawler, we have a few questions here. So one of them is, any idea how many of the fatalities from H5N1, you talked about the 52% case fatality ratio. Any of them have comorbidities, or was any of that part of the documentation that could have contributed to that higher case fatality ratio?
Yeah, so there were some studies published in the mid-2000s that looked more in depth at cases out of places like Vietnam and China and Indonesia, I think. And the majority of those patients were young and healthy. Again, there was a strong predilection for younger ages. And again, many of them kids or adolescents. And the majority of them did not have underlying comorbidities. So yeah, this is not a disease that is impacting folks with, underlying immunocompromise, or again, the elderly. This is impacting generally people who are normally at kind of the peak of their health lives.
Thank you. The next question comes, you mentioned briefly the decision to admit a patient to the BCU based upon suspicion. I think more so your thought was probably once confirmed. What criteria are you using to operationalize this strategy? And is it based upon positive testing or epi risk or both, or what sort of criteria would you utilize?
Yeah, so great question. And I think first of all, and I see Alice Sato asked a question kind of with a similar thread. So we would admit somebody certainly to the biocontainment unit who required hospitalization. So if we're and if we're going to hospitalize somebody, we would hospitalize that person in the biocontainment unit if they had a confirmed H5. Or I think if they had a strong suspicion for H5. So for instance, we had somebody with an epidemiologic risk profile and they were influenza A positive, but it was not subtypable. It wasn't H3 or H1. I think in those circumstances, we would probably admit that person to the biocontainment unit until we had more information, until we were able to actually identify the virus, et cetera. As Alice points out, there may be situations where somebody presents to healthcare, but doesn't require hospitalization. However, has a diagnosis of H5 or at least a strong suspicion, and that would obviously represent the cases that we've seen so far in this outbreak. Again, the 14 cases have all had relatively mild disease. Some have had respiratory symptoms. Many have presented primarily with conjunctivitis. So if somebody did not need hospitalization, then obviously I don't think we would admit them to our biocontainment unit. But what to do in terms of isolation going forward, I think, is an open question that would have to be addressed with state and local public health. I think home isolation for many people is appropriate and feasible. But for others who may have small children in the household or high-risk individuals, or in other ways may live in a small house with a large number of people and may not be able to effectively isolate, then using other strategies. For us, I think we have access to our national quarantine unit, so that's an easy solution where we've done that before, provided isolation care for people who really don't, are not hospitalized. But what to do for somebody who's kind of in that weird situation of can't isolate at home, but needs isolation. Those are situations that we periodically deal with in public health, including for things like TB, and those are probably going to have to be addressed on a case-by-case basis. On rare occasion, we end up actually putting those people in a hospital isolation room because that's the only option. But that's usually kind of the last resort option if we can't find any other solution.
The other question I wanted to pose or bring forward was just, can you walk through, I know there's been some recent funding provided out to public health to be able to really make an all-out effort, correct, to vaccinate for influenza our farm workers. The goal of that is just so that we have less to differentiate, or what is the rationale or science behind trying to put that in place?
I'm sorry, Shelley, I missed increasing vaccination for farm workers?
Yeah, for influenza,
yeah.
for seasonal influenza, they're making an all-out push. So can you talk a little bit about the background there and the why?
Absolutely. Well, I think, obviously part of the rationale is if we can push up vaccination levels for flu and COVID in farm workers, then we'll have fewer farm workers who are developing respiratory symptoms and presenting to healthcare. And then, essentially, because finding one of these cases is like looking for a needle in a haystack, right? As I mentioned, probably 100,000 people roughly present to U.S. healthcare on a daily basis with symptoms consistent with this disease, more when it's going to be flu season here in a few months. So if we can reduce the number of those people showing up who have a link, an epidemiological link that would raise concern, it makes the haystack a little smaller. I think that's the main point. There's also some theoretical benefit about, maybe there's some cross-protective immunity between distant influenza strains that give you protection against H5. I think, hard to know for sure, but certainly I think the main thrust is to just reduce the total burden of respiratory illness and influenza-like illness in this population to make it a little more manageable.
And then we have a little bit of a case study here as a question in the chat. There was an admission of a patient yesterday with respiratory failure. Person's doing better, but they tested positive for influenza A. Kind of late in the season, right? Because we're about ready to start the new season in a couple months. But I think we're still seeing random influenza A cases, correct?
We are. Influenza never completely goes away. But it is, we're at a relative low point in the flu season, and we should be seeing, yes, very, very small numbers of cases. So anybody who presents with severe infection and influenza A, I would subtype. And again, there's a number of different lab tests that are out there, and probably if you can't do that at your healthcare institution, sending it to public health will allow them to subtype it as well. Obviously, you're not going to get the answer back really quickly, but the other thing you can do is obviously ask questions about epidemiological links, right? And so at this point, it would really be contact with cows or poultry on farms, contact with wild birds, or potentially other wild mammals, right? If somebody had like just skinned a coyote they had killed or something, then that might be enough to at least raise my concern a little bit. Or if they're a household contact or close contact of somebody who works in one of those places, those would be the epidemiologic risk factors that I would think about as kind of raising my suspicion. If it's no other epidemiological risk factor, it'd be great to subtype it. I still think that's important, but my level of concern would be lower.
And then do we have any sense with H5N1 how long to isolate if a confirmed diagnosis comes back? Not enough history yet, or what are your thoughts?
That's a great question. I think the short answer is no, we don't have great guidance. And so I think that has to be a clinical decision that's based on symptomatology of the patient. How symptomatic are they? How sick are they? And then, probably based on repeat testing. So if somebody's symptoms have resolved, and they're test negative at that point, then I think that's an easy answer. They're probably safe to go out of isolation. If somebody's still symptomatic, I think that's a good indication they might need to still be in isolation. And if somebody still tests positive, particularly from the respiratory tract, or the conjunctiva, if they have conjunctivitis, then I think that would be a concern about sending that person back out into the community with the potential to transmit to somebody else.
Well, I think that's all of the questions in the Q&A, so I'll just pause for a couple of minutes. Any closing comments, Dr. Lawler, of anything else you would want to pass along to this group before we finish up today?
Well, I think that it's really important to continue to raise awareness among our frontline clinicians about the threat and the actions that we should be taking. It's critically important to ask questions to start to dig down into epidemiological links. Critically important to be on the lookout for folks who have a clinical syndrome that matches what we've seen so far. Very important to get public health involved early when you have somebody who meets case definitions, or at least has an epidemiological link that would indicate they're probably a person under investigation. And then early treatment is really, really important. Again, just like with COVID, you need to treat people when it appears they don't need treatment, because by the time you realize they're getting sick, it's probably too late. And again, in theory, these drugs can reduce burden of viral shedding and potentially reduce likelihood of transmission from person to person as well. So all of those things are really important. And it's really up to us right now. We're the front line. Unfortunately, we're not having a lot of success in implementing surveillance and testing in the ag sector. And so, it's probably going to be healthcare that if something happens, we're going to be the ones who are detecting the first cases that are emerging. And it may depend on how quickly we act and how effectively we act, whether we can contain an emerging pandemic at the source, or whether this breaks out and again becomes the next major pandemic, which is what we're all obviously trying to avoid. And just like everything else in public health, if we are effective in doing our job, nothing happens. So it's important to communicate what we're doing to folks and why, so that we are creating appropriate expectations. When nothing happens, it's a good thing.
It is a good thing. And just a reminder, we'll send a PDF of the slide decks today out so that you have those resources. So don't start from scratch in your organization. There's lots of good information and tools for you to grab onto and to just keep your awareness, right? So there's a lot of great resources and information to connect with on a routine basis to better understand what's going on out there. So I think with that, I'll turn it back to you, Thomas, for any closing remarks or information for the group here today.
The only thing I have is what you had already said, reiterating we can send out all those slide decks. We'll work on getting the recording up on both the website as well as our YouTube and everything like that. We'll email links out to folks. That should be hopefully within the next day or two. We'll get that taken care of and go from there. And we appreciate everybody coming to attend.
Thank you, everyone.